Hello everyone, I'm Rachael Lowe from Physiopedia. I'm absolutely delighted today to be talking to James Elliott in Chicago. Hi James, how are you today?
Hello, Rachel. Hi, I'm doing really well, thanks. Thanks for having me.
Oh, thanks so much for joining us. Now I know a little bit about your work and we've just had a little chat before we started recording, and I know a lot of your research has been in whiplash and the transition from acute to chronic pain and why that sort of thing happens. But I don't know much more about all the things that you have been getting up to because I know it's a bit broader than that. So maybe before we start chatting about all things cervical spine, could you just tell us a little bit about yourself? And for those that haven't met you before, introduce yourself and then maybe tell us a little bit about the work that you've got up to.
Oh, sure. No, I'd be delighted to appreciate that. So I, like most of the listeners, if not all the listeners, I was trained as a physiotherapist. I went to Regis University in Colorado and practiced clinically for a good 6 years full time in a practice that primarily saw patients with chronic pain from a number of different sort of disorders, whether it was trauma or just ongoing sort of conditions. And that, I'll tell you, that generated lots of ideas and desires for me professionally, and that was to pursue a PhD. And at the time, and frankly, still now, I think some of the best research coming out on chronic pain and musculoskeletal disorders was in Australia. And I was fortunate enough to meet Gwen Jull, who thankfully sort of took me on and I think somewhat like some of my ideas about what I wish to explore, and like any good advisor, and she's great. She's helped me sort of narrow that focus and brought together a team of interdisciplinary researchers. I worked with a gentleman named Graham Galloway, who's an MR physicist, a magnetic resonance physicist, and another gentleman who's a radiologist. And, you know, those are three sort of professional folks that don't necessarily work together all the time, right? So that was a really phenomenal experience in helping me sort of explore clinical questions that I had from observation I was making with patients who had chronic pain. And then ultimately that led into a postdoc opportunity with Michelle Sterling, who was just a phenomenal 3 years for me and really helped me focus my line of research, which has been primarily more mechanistic based. I admittedly am not much on trials and interventions. I very happily hand that over to my smart colleagues that do that work. And that shifted ultimately back to Chicago, which is actually where I'm originally from. I'm now 5 doors down from the house I grew up in after 27 years of being away. So I've gone full circle in life. And as I told you offline, I married a lovely physio from the UK. Who's originally from Devon and is now Scotland. But nonetheless, I've been back in Chicago at Northwestern University for the past 6.5 years. Most, if not all of my work is utilizing advanced imaging applications to look at muscle tissue, to look at spinal cord, and to look at sort of brain tissues as well, just globally speaking, in acutely injured patients. This primarily has involved motor vehicle crashes, but I've also expanded my horizons to explore opportunities in folks with known spinal cord injury, working a little bit in the domain of concussion as well, but also now looking at sleep disorders and its influence on health and its influence on muscle tissue and function. So I think that the key theme here, without going into a big, long story, is it's all very interdisciplinary. And I, like many of us, have been very fortunate to have some phenomenal mentors who've helped me sort of focus my line.
Okay, so I thought we were going to be talking just about whiplash sort of things, but now we're talking sleep disorders and concussion and spinal cord injury, so I'm intrigued. Can you, this is going to be a really tough question, I think. Can you summarize, or what are the sort of key themes that have come out of all that research that you've done?
That's too difficult of a question for me to answer. No, I'm just kidding. Again, the key thing here is we all have clinical observations. We all have clinical questions. And ultimately, what it really requires, at least to me, is knocking on the door of other disciplines who have expertise in that particular area. ultimately, what I've been really fortunate is that I've carved out a little bit of a niche, I guess, with respect to muscle tissue and composition of muscle tissue, and that my focus has been and still will be trauma, primarily from a motor vehicle crash. But I think once you start knocking on doors of other disciplines and going to other conferences. I spend an awful lot of my time going to radiology conferences. I go to emergency medicine conferences. And that is getting our work out in front of them, and that generates questions for them. So in the sleep disorders, for example, there's an ongoing Chicago area sleep study, which is one of the largest epidemiological studies in sleep medicine. And a portion of their work that they really wanted to do was look at muscle tissue and look at the potential complications or consequences on muscle tissues as a result of sleep disorders being a systemic problem. So that opened up an opportunity for them to knock on my door, and my small, albeit small, contribution to their large body of work is measurements of muscle composition and function. So I think that's just a bit of a broad example of how we can work together to answer difficult questions across a broad spectrum of conditions. Because, I think humans, as you well know probably better than I do, Rachel, they don't have a diagnosis. They have a diagnosis, but they have a whole other, biological and psychological and social factors that influence their outcomes. So that's really been quite fun to get to learn about lots of different conditions and provide a small contribution to their overall research.
Okay. So if I can bring you back to cervical spine and whiplash.
Sure.
What has been the sort of main findings from your work in that area that we can take that impacts clinical practice?
Yeah. I think the old sort of logic here is that whiplash is a very homogeneous condition and that, most people should expect to recover soon after the event. Thankfully, with work out of UQ and certainly other colleagues around the world, we now understand that whiplash is not a homogeneous condition. It's very heterogeneous. I think it's still safe to say, depending on how we define recovery, 50% of people should expect to recover soon after the injury, within the first couple months. But clearly, there is a group that has a much more complex clinical presentation. My, however small it is, contribution to that literature has been observations of degeneration, if you will, or compositional changes in muscle tissues, primarily the neck muscles, extensors and flexors. And that's been through advanced imaging and using well, no, that's not true, conventional imaging, but also now exploring it with more advanced imaging. I think it's safe to say that the literature overwhelmingly supports that very rarely, if ever, do we find a salient structural lesion in individuals after a whiplash that helps explain their symptomatology. And I quite agree with that, and I'm not arguing with that. I think most people, whether you're a primary scope provider as a physio in various parts of the world, a chiropractor, an emergency room physician, a family doc, we have guidelines that help us understand when and if imaging should be used, and that's primarily to rule out sort of osseous lesions, fractures, ligamentous instability, vascular insufficiency. Most people, once they've been screened medically, I would argue they probably don't need any more imaging. It's done. Let's just judiciously follow their sort of pathway, if you will. We have more evidence now that is, it's not perfect, but it certainly helps us characterize these individuals a little bit better. I think of Carrie Ritchie's work on developing a clinical prediction rule for risk trajectories and pathways of recovery. That's a great start for a clinician to utilize that tomorrow in their clinic to help them get a better handle on where these patients may be going. And I think everyone realizes those trajectories aren't fixed.
Okay, so we've talked about how you might identify this individual who is perhaps not on the best trajectory, as you describe it. I can't say that word. We've been who are looking at maybe the poorer prognosis, and you've talked about using the clinical prediction rules and these basic tools like the visual analog scale, pain scales, and body charts, and then some of the other outcome measures that you mentioned. once we've identified some of these people, what would you say is a good approach for intervention? And I know you've mentioned that, people ask you all the time, so what do we do about it? But what would you say at the moment, what would you advise clinicians to do or to consider in intervention with these people that we've identified?
Yeah, I think if I think it's safe to assume that there are three trajectories, right? There's a recovery trajectory. People are going to recover quite nicely. I think that group is best suited for the recent findings in randomized control trials of advice, assurance. Let them be, let them recover, monitor them to ensure recovery is occurring, and if it is, that's it. Off they go. Then you have this sort of 25-ish% that seem to be on a poor recovery trajectory. I think that opens up more for understanding the mechanisms that could be driving it. What are the key drivers in this clinical examination here that you find? Is it more of a nociceptive peripheral input from an angry facet joint, whatever it may be? Or does it appear to have signs that are more centrally driven? Are these people who, I'm being very general here, maybe they don't like the ice bag on the back of their neck. Maybe they're demonstrating widespread sort of hyperalgesia. Maybe they show signs of stress and anxiety. I think those folks, it's best trying to figure out what's the key driver here and intervene from there. Now that group probably would benefit, and we don't know this for sure, but would benefit more from a multidisciplinary approach. They may need more pharmaceuticals, and I'm careful what I say there because that's not my area of expertise by any means. I would refer to my physician friends. They may need psychological intervention as well. There is some emerging evidence that cognitive behavioral therapy could be very appropriate for those folks, but clearly more needs to be done there to draw any definitive conclusions. Where it gets a little challenging, obviously, is that not everyone sits on those two spectrums. You don't have just this dichotomous world of, yep, recovery and nope, no recovery. There's a group that seems to be in the middle, and they haven't quite figured out where they're going yet. I think that also argues for a good mechanistic approach, and we're very good at that, at figuring out what seems to be the biggest driver, what seems to be dictating this sort of presentation in this patient. Monitor them judiciously, use your outcome measures that you use. I think have your go-to toolbox to figure out what's the biggest driver here. I will say in May of this year, Michelle Sterling and Linda Carroll, Michele Curatola, Helgi Cash, myself, and Dave Walton, with Michelle's leadership, we launched an international consortium on Whiplash. There will be a nice paper that will come out of this that talks about trials and what are the domains that trials should actually investigate, and what are the key domains to this particular condition. And underneath those key domains, there will be a suggestion, not dictating, but a suggestion of these are the tools we would recommend you use in clinical practice. That's obviously very much needed, because if you think about, from a research perspective of doing pooled analyses and taking all the trials that have been done, well, that's difficult when no one's really collecting the same outcome measures. So I think we're going to see a vast increase in our knowledge of this condition over the next 5-10 years for sure. But as of today, if I'm a clinician treating these patients, I do what I do every day, and that is try to figure out what's the biggest driver here. If that patient appears to be on this trajectory that's poor recovery, I wouldn't sound the alarms and make them feel they're never going to get any better, but I would try to just take a little bit more time to dig deeper and figure out, is there an emotional component to this? Is there a cognitive component to this? Is there a nociceptive component to it? Neuropathic, central neurogenic, those types of things. And there are tools that can be used to identify that.
Which tools?
Wonderful. So, if I'm thinking of, cognitive sort of aspects, you might use a fear avoidance behavior sort of questionnaire. You may use the Tampa scale of kinesiophobia. Seems to hold up better in low back pain than it does neck pain. From an emotional perspective, I might use something like the impact event scale to figure out, is there more signs that are consistent with post-traumatic stress, not necessarily PTSD, but post-traumatic stress. From a nociceptive component, I could use, hold on a second. a psychophysical test of algometry.
Yeah, nice.
I might take my handheld pressure pain algometer and maybe just do a nice little test on the upper fibers of the trapezius and look for signs that would be maybe consistent of a local nociception. Dave Walton published a paper a couple years ago on we reconciled data from Denmark, Australia, Canada, and America. It's a little over 1,200 patients with neck pain, chronic neck pain. And there's really nice values in there by which clinicians can use to compare how does their patient compare to the data reported in that paper. And Dave was able to find different sort of groups in that, people who are very sensitive just here, but then there's also people who are sensitive on the neck, but they're also sensitive distal on the tibialis anterior. To me, now I don't have all the answers for this, nor does Dave or Michelle or anybody else, but if they're sensitive in both areas and there's signs of arousal and they have high NDI scores, maybe that's indicative more of a centrally driven process. And that's maybe a patient who probably needs a little bit more of an interdisciplinary approach in treating this. I think with those findings, I'm a lot more confident in my communication with a referring physician, with other stakeholders that are managing this, versus how I was in my early days of, I can't help you and I don't know why. Now I have answers that can actually inform my communication with the patient. Again, not, hey, you're condemned to a life of chronic pain, but I think it demystifies the condition for them, because remember, they're looking for answers too. And nobody, unfortunately, seems to have good answers for them.
I think you're highlighting a key thing that physiotherapists, well, anyone in life and whatever work they're doing, is that it's almost like, if you get stuck with these patients, or if you're struggling with them, if you don't feel like you have the knowledge, you gather as much knowledge as you can with all the tools you have, and then don't be afraid to ask questions and to talk to your colleagues and to communicate with the interdisciplinary team, because that's the patients. And I think I would say, don't be afraid to tell the patient that you're doing that either, because surely that is a good approach and that patients will appreciate that approach.
Yeah, I quite agree. I mean, at the end of the day, it's a patient-practitioner relationship that you're building, right? And I know we've heard that a lot over the past few years, but it's so true. Physicians are going to be very honest with their patient. I think if there's a disease going on, they're not going to lie, and not lie, but they wouldn't sugarcoat it. They would tell them. Clearly, if I've got X, Y, and Z things on my exam, then I'm going to have a more informed communication with the patient about why I think a referral to this practitioner would be a good idea for them to ultimately help them. I agree. I think we're, again, getting more and more knowledgeable about the condition. We're understanding that it's very heterogeneous. It's not this homogeneous sort of condition. And there's many factors that can and do drive it. If I think about the muscle work that we've done, to me, again, that's just a little piece to this whole puzzle. It's maybe what I'm known for, but fine, that's how I get funded, that's how I put food on my table, but it's also because I love that work. It's very mechanistic and it's very fulfilling.
Okay, good. So we've talked through these different groups of people and presenting after trauma, so whiplash, and how they might present. So 50% who may just recover and it's quite a straightforward process, and then the others that we need to pay more attention to, and that are on a different sort of pathway. And we've talked about this in relation to whiplash, which I know is your area of work. Can we extrapolate all that we've talked about today to other pain presentations in the cervical spine?
Things like cervicogenic headache and things like non-traumatic neck pain.
Non-traumatic neck pain, yeah.
Yeah.
Maybe,
I think...
Yeah, the more non-specific stuff.
Sure. Well, I'll answer that, I think, in two ways. So the work that we've done, we've identified that these changes that we have seen consistently in muscle tissues does appear to be rather unique with respect to magnitude and how fast it changes in the traumatic aspect. So it seems like traumatic factors are playing a role. Those traumatic factors, there's a fairly long laundry list of things that could be causing this. You could go from disuse, inactivity, You could say something like denervation. We haven't studied that, to be honest. I haven't stuck needles in people's muscles yet. But there also could be things like stress system dysregulation. One of our current theories is I collect blood samples like many people do in the emergency medicine department, and we look at various microRNA candidates and their influence on genetics. And is that causing these changes in some of these muscle tissues? So those are all the basic science aspects. With respect to those muscle changes, we haven't seen them to the same magnitude in non-traumatic neck pain, which again, I think increases my confidence that there's a consequence to the trauma in these particular muscles. But I think, again, going back to like traumatic neck pain and whatnot, I mean, the evidence would suggest that manual therapy and exercise and a combination thereof is probably the best way to go. That's sort of our bread and butter. I think don't change it. But I think it's also, we're becoming more and more aware that every person has a unique experience with their pain, right? If we just use a numeric pain rating scale, it's sort of like, Rachel, 0 out of 10, how much do you love living in France? And Rachel says, oh, 9. I said, well, you don't seem very happy, but that's your 9. My 9 is, oh my God, it's a 9. So everybody's very, very different, right? So I think just take the time to dig a little deeper to try and figure out what's unique about that patient. We had a paper out a little while ago on how do we measure someone's pain experience. And by no means am I the expert in the world on pain, but I think the colleagues that I brought into this paper do have some expertise in that. And we framed it around fMRI, functional magnetic resonance of the brain, and albeit emerging and albeit phenomenal and albeit an opportunity to work with other disciplines, fMRI in isolation of the brain isn't going to tell us everything we need to know. There's a person there who has their own experiences. I think one of the nice things about being in Chicago is that we're a very diverse city, ethnically. So our research, when we welcome acutely injured folks to the emergency medicine department, are from all walks of life and all socioeconomic statuses and race, religion, beliefs, etc. So it is a epidemiological soup to try and look at all the epigenetic factors that could be driving the clinical course. The reason I bring that up is that clearly those patients are going to come to your clinic and your rooms. So we need to have the right tools to identify what seems to be driving it for that particular person, because manual therapy and exercise seems to have the best evidence, but it may not work for everybody. There may need to be other things we got to consider.
Yeah, absolutely. Okay. So from here, we've talked a little bit about non-specific neck pain and also the whiplash side of things. Is there anything, if I was to say to you, if you could give a few top tips to clinicians to take into their practice tomorrow when they're seeing individuals with neck pain, whiplash or neck pain, what sort of top tips would you give to clinicians who might be wanting to take something into their practice tomorrow?
Yeah, sure. I think we're all trained very well in the biomechanics of injury and the structural aspects of injury. Obviously, perform that exam. Look for your articular restrictions, look for your articular hypo and hypermobilities, but don't be surprised if it's inconsistent. Also take some time to look at some of the other factors that can and probably do drive the clinical course for these patients. Consider their belief system, consider their own contextual beliefs of their pain. I think gain some understanding of other outcome measures that maybe you haven't used in the past. So maybe some of your listeners today haven't heard of the Brief Illness Perceptions Questionnaire, the BIPQ. Have a look at it. It's free. You can Google it and you can find it. It's a very easy tool to use. I love it because it's not a tool that you would sum the score of and then just sort of say, oh, there are 42.
Yeah.
It allows you to actually look at their individual item responses to it as to, do they feel they're in control of this situation? 0 out of 10. 10 is I'm totally in control. 0, I have no control. One of the questions gets at frailty. How do you feel it would be likely you would re-injure yourself? 10 is yes, 0 is no. Well, geez, if they're scoring at 7, 8, 9, 10 on that item, I'm probably not going to give them an aggressive exercise approach day one. And I would imagine that if they scored high on that, they'd probably score pretty low on the control question. They don't feel they have a lot of control. So I think that invites us, it gives us a green light to say, right, this is probably someone who I'm just going to sit down and educate and talk to and reassure. However, on the flip of that, if they have total control over this and they don't feel frail, well, I might be a bit more aggressive. The aggravating factors don't seem to be there. So I guess my take is, and that's a bit of a connecting flight to get to the point, I'm sorry, is just become more aware of various outcome measures that can be used and are easy to use. You don't have to have $20,000 US to go out and buy an algometer. I might buy this for $395 US. And I could use this, and I can compare my data with my patient to what's in the literature with Dave Walton's paper. The other thing I would say, Rachel, is that don't rely on this in isolation. If you're just doing that and then making treatment decisions on that, you're probably limited for sure. I think it's this whole idea that I love this term triangulation, right? So you start to take data from multiple different sources and then put them together. And are they all pointing in the same direction? Emotional, cognitive, nociceptive, what it may be. And I actually recently saw on Twitter, I saw Peter O'Sullivan was given a talk about this very idea of triangulation. And I think that's magic because he obviously has a wide, I don't want to say following, but a wide outreach, if you will. And that to me is a different age from where I came from physio school and probably where you came from, where it was very biomechanically and structurally based. I still use that in my clinical practice, but I love the idea that we're now starting to consider the different factors that can and probably do drive this. I wouldn't get myself in trouble, I hope, by saying that, if all you were doing was just sort of a structural based management program, that gets many people better, but it might not get everybody better. So now you start to consider the other drivers, and that would justify your referral for that particular patient or justify why you discharge them.
So I think while I'm listening to you here, I think summarizing what you're talking through is that you would advocate a thorough and good examination to identify, obviously, which is what we all need to do, but also to make that, so your manual examination, physical examination as well, but then in your questioning, in your communication, in the use of the outcome measures, to individualize that for patients because they're all different and we have no idea how each person's going to be different, how they're going to present, so individualize that for each person. And then on top of that, we need to have a very broad toolbox that we can call on things for how each individual person presents and and that's where the clinical reasoning comes in, how we have to reason what we think is going to work for that patient for how that individual's presenting. Would that be a fair sort of summary of?
Yeah. Look, I think that's great. I mean, I'm reminded of your fellow countryman Roger Carey's work and N of one, and I believe that. I think that's a very nice message that he and his team and others are, getting out there. So by all means, I think individualize it to the patient, tailor your treatment from there. It's an individualized sort of world in some respects, and that's how we're going to assess and treat these folks for sure.
Definitely.
Yeah.
So James, we've respectful of your time today. We've talked about quite a lot. Is there anything that we haven't talked about that you would like to share with the world?
Oh my God, Rachel.
This is your opportunity.
Oh dear God, if anyone really wants to listen or cares about it, really, I guess. Look, I guess this is probably an opportunity to share some life changes in my wife and I's world. We've had the most amazing, nearly 7 years here in Chicago. And I am forever grateful for the training I've received here at Northwestern. It's a phenomenal university, and the department is super supportive. It's a very collegial sort of university as far as cross-disciplinary work. So I've benefited greatly from that. It's allowed me to expand my horizons and do different things. But By virtue of that, I've been very fortunate to receive an offer to shift my family back to Australia. And my wife and I, my wife in particular, has very strong family ties and historical ties to Australia. Our youngest was born there. I was trained there. And I'm going to be shifting my young family back to Sydney. And I'm taking a very different position. I'll be a professor in allied health, and it's a conjoint position between University of Sydney and the North Sydney Local Health District. So about 1,000 some odd allied health practitioners. And my purview will be to be very broad as far as my research will be concerned, which is great. I welcome that. One thing I think I'm good at is connecting, and I love networking folks. So this will be a lot of fun to, ultimately improve the provision of care to the public for any number of different musculoskeletal and neuromusculoskeletal disorders that people come to see us for. So it's a super exciting time, and I can't wait. And our kids are delighted.
Oh, that's very exciting news. Thank you very much for sharing it with us here. Congratulations on your new position. The United States will be very sad and Australia will be very happy, I'm sure. So, we look forward to the work that you're going to be doing down there. Will it be quite different, or are you not too sure what direction you'll be taking with that yet?
No, there will certainly be some different aspects to it, for sure. I am very happy to report that my lab will actually stay here in Chicago and will continue to sort of keep the doors open for business. Again, that's certainly motor vehicle crashes, but it's also other types of trauma, which I have a personal sort of reason for wanting to be and wanting to expand. My work has now moved more into spinal cord injury, which is very rewarding for me. And personally, my nephew was the victim of a drunk driver. And he's a C6 complete spinal cord injury. And these are all, I guess I will say one other thing, Rachel, because anytime you give me an opportunity, I will do this. Most of these injuries that I come across are preventable injuries. They are because someone was on their phone, someone was in a hurry, someone made a bad decision to have a few drinks and then get behind the wheel. And distracted driving, be it from drink, drug, or phone, is not compatible with operating a motor vehicle. These aren't accidents. They are motor vehicle crashes, right? So they are preventable injuries. And I guess I asked the question, and maybe for others to think about, is what will it take for us to never again engage in distracted driving or drink driving? It's maddening, but I guess I would love for people to just put me out of a job.
Yeah.
So I don't have to deal with that anymore. I see more trauma in our emergency medicine department working with my physician colleagues than I ever thought I'd see in my life. And a lot of it is actually very preventable trauma.
Yeah, and I guess that's an amazing message to send to everyone. And from your personal point of view and from the things that you see in your daily work as well. And I don't think that message can come from anyone more suited to send it. So a good message. Thank you very much.
Thank you.
James, for people who want to find out more about you, where can we find you online? Where can they find you online?
Oh, sure. Well, my website, which will actually change here towards the end of the year, but at the moment it's www.nirl.nu. That's neural.nu. That gives a little bit of a background of our lab here in Chicago. My lab is I have 2 PhD students just now. One's a mechanical engineer and the other's a medical physicist. So again, keeping with that theme of interdisciplinary type work, and I'm a physio,
Yeah.
which is really wonderful. But by all means, I'm somewhat pathologically attached to my email, so people can also reach me there if they want to at j-elliott, 2 L's, 2 T's, at northwestern.edu, and I will let you know when that changes in Sydney.
And I believe you're on Twitter?
Oh, gosh, I forgot about that. Yes. at Elliott Jim, Elliott Jim.
Yeah, so a good place to connect with James would be on Twitter. I think you're quite active on there, so I'm sure he will be there responding to tweets as well. So, James, it's been an absolute pleasure to talk to you today. Thank you very much for sharing your knowledge with us. It's always very useful to try and translate some of the research and work and knowledge that you have into clinical practice all around the world. So thank you for talking to us today.
Well, it's a pleasure, and all thanks to you, Rachel. Thank you.